Thank you, John, and thanks, Manal, for that wonderful talk. And to take us through modeling eliminating strategies in Africa is Shevanthi, who will be joining us virtually. She is a consultant hepatologist at Imperial College in London. She's done quite a lot of work in clinical fields of epidemiology, applied modeling and health economics in guiding public health policies, which I think is applicable to us in eliminating viral hepatitis in low to middle income countries. She is a WHO advisor and she has worked quite extensively with vaccines. So over to you, Shevanthi.
Thank you for inviting me to present at this year's COLDA conference, and I'll be talking about modelling hepatitis B elimination strategies in Africa. I have no conflicts of interest to declare. So I'm going to start with a slide on a brief background of what role epidemiological modelling plays. I see modelling as a tool which provides a means by which data of different types can be combined under strictly defined rules. Importantly, modelling does not replace empirical data, but the strength of modelling efforts is dependent on the quality of the data available. It can ask many questions, like, is it worth doing something? And what is the projected health impact? Is it possible to achieve something particular that you are looking for? How can it be done and in a way that represents best value for money? And how much does it cost overall? How can we monitor the progress of our intervention? Importantly, it can also identify key drivers of uncertainty in the projections, and this in turn can inform new research. So hepatitis B, the burden we know is very high globally, with nearly 300 million persons infected with the virus and about 81 million living with hepatitis B in WHO Afro region. Many countries in Africa actually account for more than 80% of the global burden of hepatitis B surface antigen positive infections. And these two panels are from the Polaris Observatory study in 2018 and show on the left-hand panel the hepatitis B surface antigen prevalence in the general population, and on the right-hand panel in the under 5-year-olds. And as you can see, a lot of the countries where the burden is the highest is in the WHO Afro region. Now, we all are very well aware in this forum the importance of hepatitis B mother-to-child transmission. But a few summary points. So we know the WHO elimination targets now aim for a less than 0.1% surface antigen prevalence in children by 2030. But the current 5-year-old prevalence is 2.5% in Africa. And hepatitis B mother-to-child transmission is now the major mode of residual hepatitis B transmission. And this is partly due to the successes of infant vaccination at interrupting horizontal transmission, both in the region and globally. Perinatal infection is particularly important as the risk of developing chronic infection is higher if infected at birth. And also there is data suggesting that it may lead to more severe liver disease progression. This is a WHO incremental approach to prevention of early hepatitis B infection. And the foundation and the cornerstone, as we all are aware, is at least 3 doses of hepatitis B vaccination, including a timely birth dose within 24 hours. Then they suggest hepatitis B surface antigen testing, linkage to care and follow-up of infants, and HBIG when available. Then at the top of the pyramid is maternal antiviral prophylaxis if the maternal hepatitis B DNA level is high or the hepatitis B e antigen. Now, we'll talk through some of the evidence from the region about these different levels of intervention for prevention of mother-to-child transmission. So unfortunately, there is low coverage of hepatitis B birth dose vaccination in Africa. Only 13 countries in the region have introduced a birth dose vaccination into their national policy, and regional coverage of birth dose vaccination is estimated to be 17% in the 2021 WHO-UNICEF estimates. Hepatitis B birth dose vaccination, even when it forms some part of national policy, is often not given within the recommended 24-hour window when the effectiveness of the birth dose vaccination is the highest. And there are many logistical, financial barriers, including out-of-hospital births and cold chain requirement, which make the birth dose vaccination strategy within 24 hours of birth a difficult strategy to implement. The figure on the right is from a recent review, which highlights the countries in the region which have adopted birth dose vaccination. So this is the results of a modelling study we did about the impact of hepatitis B birth dose vaccination scale up. We included 110 low and middle income countries throughout the world, and we had country level models and aggregated the results by WHO region. We found that the impact of scaling up timely hepatitis B birth dose vaccination to 90% WHO recommended coverage levels could prevent 710,000 deaths globally in the 2020 to 2030 birth cohorts. And as you can see from the figure on the right, which shows birth cohort in the x-axis and hepatitis B related deaths in the y-axis, this is broken down by region, and 70% of deaths averted would be in Africa, i.e. 500,000 hepatitis B related deaths. And this is primarily because the burden of hepatitis B infection is high and the coverage of hepatitis B birth dose vaccination currently is low. So it has the most to gain in terms of improving health impact. Unfortunately, we have also seen the potential indirect effects of COVID-19 disruptions over the last couple of years. The WHO pulse surveys have shown disruptions to essential health services, including antenatal care, facility-based births, routine immunization services, both in health facilities and outreach services. As part of the modelling study, we modelled the impact of theoretical temporary drops in hepatitis B birth dose coverage in 2020. And as you can see from these different panels, we modelled a 5% drop, 10% drop, 15% and 20% in each of the world regions. And what we saw was a 20% drop in 2020 coverage could lead to additional 15,000 deaths. And these deaths would be concentrated on the WHO WIPRO and SERO regions, partly because of the high burden, but also because they already have quite good levels of coverage of hepatitis B birth dose. Conversely, when we look at the impact of delays to hepatitis B birth dose scale up, this is compared to delayed expansion. This is compared to the 90% scale up, which is the ambitious scenario. We see a different pattern. Here, we have 3 levels of delay to starting or scaling up hepatitis B birth dose. And here what you see is the blue area, which is WHO Afro region, could be the most affected. And at worst, this could lead to 580,000 avoidable deaths globally in the 2020 to 2030 birth cohort. So really, this is a theoretical representation of what health losses we can have by just delaying scale up of birth dose vaccination. Now, there are many studies that have demonstrated the cost effectiveness of hepatitis B birth dose vaccination, both globally and in the region. A few studies that I've highlighted here, which are from Mozambique, Ethiopia, Burkina Faso, and a model to sub-Saharan Africa with a focus on Cameroon data, have all shown that the ISA, the incremental cost effectiveness ratio of implementing hepatitis B birth dose, in addition to infant vaccination, falls below the country-specific willingness to pay threshold. These studies included different cost components of the hepatitis B birth dose vaccination. There's also been studies looking at some strategies to overcome some of the main barriers to hepatitis B birth dose vaccination, which include lack of cold chain and difficulty of reaching community births. A global modelling strategy by Seaman et al., published a couple of years ago, used a combination of controlled temperature chain and compact pre-filled auto-disposable devices, and found the combination can increase the coverage of hepatitis B birth dose to 90% and could be cost-saving in 5 out of 6 world regions, including WHO Afro. And this is primarily due to the ability to bypass the cold chain and to deliver a birth dose vaccination in community births. Now, moving on to antiviral prophylaxis in pregnancy, we've talked about birth dose vaccination, which is the foundation and cornerstone. But for antiviral prophylaxis in pregnancy, I'm going to present the results of a recent study that we have done, looking at the impact and cost effectiveness of the WHO recommended strategies for antiviral prophylaxis in pregnancy. In this slide, we look at hepatitis B DNA guided, which we call PAP-VL, and hepatitis E antigen guided, PAP-E antigen strategies, which are the 2 WHO recommended strategies. We compared these strategies to hepatitis B birth dose scale-up in 110 countries, and we evaluated the cost effectiveness relative to country-specific cost effectiveness thresholds as suggested by Ochelek et al. And what we can see from the figure on the right is 2 strategies, PAP-E antigen and PAP viral load, at central cost assumptions, which is the yellow top panel, and optimistic cost assumptions. And we see whether it's cost effective. If it is cost effective, the country dot lies to the left of the dotted line, where the blue arrow is. And if it's likely not to be cost effective, it lies to the right of the dotted line. And what we can see is the PAP strategies are found to be cost effective at central cost assumptions in about 28 out of the 110 countries modelled. But if the costs are reduced, then it may be cost effective in nearly half of the countries modelled. So really, this is a global level analysis, but with country level epidemiology, but shows that country level planning is really needed about implementation and procuring diagnostics and test kits at optimal costs to make this intervention cost effective. This is part of the same study where we look at how the relative cost effectiveness, we look at the relative cost effectiveness of the DNA and E antigen guided strategies. And really, it depends on the two and what your country has access to in terms of viral load costs and E antigen. In the study, we modelled an optimistic, not an optimistic, a price for the diagnostics that could be used if the country was to procure in mass. But we know that currently these prices are not available in most countries. And therefore, this panel gives an idea for different countries and regions to weigh up the relative costs and benefits of the e-antigen versus viral load strategies. Then the other analysis we did is we explored the cost effectiveness of a theoretical universal PAP strategy versus the WHO DNA guided strategy. And this theoretical strategy is to give all pregnant women TDF without risk stratification, i.e. without a second diagnostic test of DNA or e-antigen, which we called PAP universal. And what we found is that overall, PAP universal is more cost effective than PAP viral load in many countries, but it still doesn't fall below the cost effectiveness threshold in most of the countries modelled. Also, tenofovir usage in the PAP universal is 5 times higher than in the PAP viral load strategy. So 77 million versus 44 million pregnant women requiring treatment on a global level. And again, the relative cost effectiveness depends on the relative costs of the diagnostic tests for viral load and antiviral treatment. So we explored the space in all the countries, and this panel is, each grey line represents a country in the WHO Afro region. Now here's just a summary of a few other studies that look at antiviral prophylaxis in pregnancy and the cost effectiveness. In Namibia, the following strategies were cost effective compared to the Namibian willingness to pay threshold. So they found adding universal hepatitis B birth dose and HBIG to neonates born to all surface antigen positive mothers was cost effective, and the addition of maternal antiviral prophylaxis using an e-antigen guided approach rather than a viral load guided approach. And these fell below the Namibian threshold. In South Africa, another study modelled strategies for tenofovir in pregnancy in addition to routine vaccination, and again found that treating all surface antigen positive women was cost effective without risk stratification compared to the South African willingness to pay threshold, which is higher than in many countries in the region. Both these studies did use static cohort models rather than dynamic transmission models. In Cambodia, so outside the region, there was an interesting study which showed the integration of elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B was found to be highly cost-effective. So really thinking beyond single diseases and integrating into platforms can improve the cost effectiveness of these strategies. Now I've focused mainly about modelling of prevention and PMTCT interventions, which is actually where the majority of the studies lie in the region. But I'm just going to also cover briefly the impact of hepatitis B screening and treatment. Now, this is a global level analysis looking at the impact of different interventions incrementally on hepatitis B related deaths. And what we could see was that screen and treat is really needed to impact on hepatitis B related deaths, because the prevention efforts are going to take a while to impact on the deaths. A study in 2019 by WHO and colleagues looked at the additional resources needed for viral hepatitis elimination, and they estimated the costs of implementing the WHO recommended hepatitis B and C testing and treatment strategies in 67 countries from 2016 to 2030. And they modelled 2 scenarios, a progress scenario and a much more ambitious scenario where they treated 93.8 million people with hepatitis B and C. And as you can see, these are large costs. It represents an additional 58 or 27 billion over that time period, depending on which strategy is needed. And then the panel on the right, they show the annual breakdown of the costs in billions of these different scenarios. So really here, modelling is used to calculate the overall costs of a strategy and a combined strategy between hepatitis B and C. On a country level, our group, the prolific group, looked in the Gambia and found that community-based screening and treatment with tenofovir for adults already infected with hepatitis B infection was feasible and had an incremental cost-effectiveness ratio of about 1 times GDP per capita in the Gambia. So there aren't many country-level analyses about testing and treatment in community settings. So I've given some examples of where modelling has been used to inform or guide public health policy in the field of viral hepatitis in the region, but we do really need to note, as I said before, that modelling doesn't replace empirical data. And unfortunately, there are many data gaps throughout the world, especially on viral hepatitis. In Africa, the majority of existing data on hepatitis B epidemiology and effectiveness of hepatitis B interventions are from Asia or other settings. So there is now accumulating data from the region, which is great, and it's informing the policy and modelling. But for example, the effectiveness of hepatitis B birth dose vaccination, there's limited studies in the African region about whether the effectiveness differs from Asia. The current burden estimates, particularly in under 5-year-olds, is uncertain. And the panel on the right is just taken from the Polaris data again. And it shows the countries with the largest uncertainty in 5-year-old prevalence in estimates. And we can see Nigeria, Angola, Central African Republic, Zimbabwe, and Chad among the top 5 that drive the uncertainty. So really, some of these data gaps need to be filled. And then furthermore, there's uncertainty around the cascade of care, the costs and optimal models of care envisaged for these various interventions scale up. And this, and more clarity on this and more empirical data on this will obviously guide the modelling estimates. So in summary, some progress has been made, but coverage of hepatitis B PMT-CT interventions and testing and treatment remains relatively low in the region. There's accumulating evidence on the impact and cost effectiveness of increasing prevention and treatment interventions. And there's a variety of roles that modelling can play to guide public health policy, both at global and country levels. For example, it can make the case, it can guide strategy decisions, it can monitor progress, and also it can be used as a tool to explore new, novel or theoretical strategies. Country-level analyses are very useful to inform local policy, taking into account local considerations, epidemiology, and health systems constraints. However, better empirical data will help refine these epidemiological projections, and data systems should be strengthened alongside intervention scale-up. So thank you very much. I'd like to thank all my collaborators, and I'm happy to take any questions.
Thank you very much, Shri, for that interesting and excellent talk. I can reassure you that you kept everyone entertained and glued to the screens. Perhaps I can kick off with a question. I like your strategy of test and treat. I think everyone in the audience will agree that most of our patients get lost to follow up, despite education, despite efforts to encourage them to adhere to therapy. What are your thoughts regarding keeping patients or young pregnant ladies who plan to have future pregnancy on long-term tenofovir or whatever treatment that is available in your country, regardless of whether there's an indication to treat or not? The second part of my question, sorry, second part is in a country that is quite diverse socio-economy-wise. We've got areas that are very remote, those we call rural areas, that have got really limited, care to health facilities. I wanted to know how effective is a single dose vaccine. The reason I'm asking this is, obviously, most people deliver in hospital. If we're struggling to convince our government to implement universal birth dose vaccines, but perhaps if we choose certain areas and say, because we know that these young babies won't be followed up, most of them are looked after by grandparents, could we perhaps make an argument for just administering as soon as the mommy delivers birth dose vaccine, and whether they get vaccinated after that, how effective vaccine in preventing hepatitis B?
So thank you very much for that. Well, I can answer them all, but I will have give my start with the second one about the birth dose. I don't know if birth doses without the substance. I don't know the data on that, and if there's any data. Infant vaccination has started first, and then with the 3 doses. So I can't comment completely on that. But what I would say is that because the 3 doses of vaccination starting at 6 weeks of age, the coverage is relatively high because it's integrated into the EPI and the pentavalent schedules. The challenge is often the birth dose. So if you say, I think we should push for the birth dose to be implemented, particularly for the reasons you say, but if we can get the birth dose in, particularly for those who are born to the surface antigen positive mothers, then actually there's a higher likelihood that the other 3 doses or 2 doses will follow. Because the coverage of birth dose is 17% in WHO AFRO, whereas the coverage of the subsequent, 3 doses within the EPI is, I think the latest figures around 75 or 80% in the region. So I think bottleneck is that 24-hour period rather than the others. But I would be interested to hear other people's opinions as well. And then going to the test and treat strategy. So I think at the moment it's still a theoretical strategy. And what our modelling, suggests is that although it can be a bit more cost effective than the viral load strategy, it's still not necessarily cost effective and leads to a lot of women that wouldn't otherwise have treatment going on treatment. Yes, it's simplified, it might be more feasible, there's other logistical things to think about, but it is something to consider and test empirically. Now, whether we target the tenofovir to women with high viral load or give it to everyone, I think that challenge that you mentioned of adherence to tenofovir throughout pregnancy will be the challenge. Just because we're giving it to more people doesn't mean that the adherence is necessarily going to be higher. But I think the experiences of the HIV programs have shown quite a good adherence to tenofovir containing regimens during pregnancy as an HIV PMTCT intervention. So I think really it's about training and education and integration within existing services so that knowledge that's been gained in the past is also added to hepatitis B.
Thank you. Thank you very much. We've got a couple of questions from the floor. We'll take yours first.
Thank you. Kind of building off of the initial question about the universal strategy. So, excuse me. So in Zambia and Malawi, where I do a lot of training of health workers, the prevalence of HIV is so high that 10% or more of the population is taking ARVs with tenofovir. And physicians often complain when I tell them, when you have a pregnant woman with surface antigen positive, HIV negative, you need to go through the algorithm to determine eligibility, plan for the birth dose, HBIG. They say, why can't I just treat here and now? Because the medication is there in my pharmacy. And what is now discussed informally is the idea of just treating until the baby is vaccinated. So i.e. just giving antenatal tenofovir for that period of pregnancy and the initial postpartum period. So would that change the cost effectiveness argument if you weren't giving lifelong treatment, but you were just giving antenatal tenofovir for a period of 3 to 5 months? That's my question.
Yeah, so that's a very good question. And I think, so just to clarify, in the modelling, we did just put the peripartum tenofovir prophylaxis. So it was modelled to be a 4-month course of tenofovir rather than lifelong treatment. So this is even with the 4-month, which is obviously very cheap, but the relative benefits and improvement would be depending on how expensive the viral load is versus the tenofovir treatment. So yes, this is just for the short course rather than lifelong. We could also take into account those that need to stay on it lifelong, but for this analysis we didn't. But it is a good point. It might just be easier, but does it work as well as a birth dose? We don't yet know. Because is it an alternative to birth dose? I see it more as an addition to birth dose, unless we have further data showing that it works as well, which it might do.
Just a question here. We're talking about e-antigen positive mothers and not negative mothers, or both?
Yes.
I think, Shevanthi, you're talking about the antigen positive mothers or just the S antigen positive? Because that's a different, I think that's a different conversation.
So I think Mike's comment was related to treating all surface antigen positive mothers.
Yeah, okay.
Yeah.
Okay.
I think, yeah.
I think there's Philip's was said. Thanks.
Thank you. Well, just continuing on the same theme. Hi, Shevanthi. I'm just trying to sort of tease apart some of this test and treat, or test and prophylax approach. I mean, it was in recognition that the recommendation from WHO on the use of antiviral prophylaxis contingent on those with a high hepatitis D DNA above 200,000 or e-antigen positive was just not being adopted. It just was not being implemented. And so that is why in the thinking and planning for the updated hepatitis B guidelines was the consideration of the question of a conditional recommendation, as it would be conditional on the circumstance if you don't have access to those assays of prophylaxing all. And so the modelling being given there won't be really observational data or any clinical trials needing the modelling, and and we discussed this. But Shevanthi, what I was surprised by was that there wasn't more of an effect. Did you capture the fact that the reality is very low uptake in sub-Saharan Africa of this tailored recommendation? So you're starting from a very low base, and the cost of the viral load assay, which is still relatively high. So I mean, why was it not greater? And perhaps we didn't see all the data, but can you just elaborate a bit more? Why not? Because this is very much where we're leading to in terms of future recommendations.
Thanks, Philippa. So yes, I didn't present all for the interest of time, and everyone didn't want to bore everyone with all the detail. But so we actually looked at, in addition to birth dose, the treat-all or the universal prophylaxis strategy, and we compared it as well to the gold standard, if you like, the viral load guided strategy. And we didn't look at different levels of uptake. Of course, that's another thing we could say. We could say, well, viral load is only done in X%, so how much better is it? And that's something we could do, but that's not what was part of the analysis. But what we did was explore the parameter space of the different costs of antiviral therapy compared to the baseline, and the different costs of hepatitis B DNA, again, compared to the baseline. Because really, that was what will affect country-level decisions about which, or one of the factors, about which strategy they would go for. Because if you have access to a low-cost hepatitis B DNA, maybe in a country or in an urban setting within a country, then maybe that still is the preferred strategy, rather than over-treating women. So that's what we did. We sort of explored the parameter space of the different relative cost assumptions to see which would be cost-effective in relative proportions. I don't know if that answers your question, but yeah, happy to discuss in more detail.
Are you happy? Okay. I think. Sorry,
Shevanthi, this is Jeff Shaker. Thank you for the presentation. It's fine to model treating all pregnant women for a finite period of 4 to 5 months if they're HBsAg positive. On the back of an envelope, I would draw up some of the pros. Some of the pros are clearly you'd suppress as you wish to viremia, and it would have a beneficial effect. The other pro is you wouldn't need the adjunctive testing for DNA or E antigen. But you can also draw up a list of cons. This is a very fraught strategy, and I'm sure as a clinician you understand it's good to fit into a model, but in the real world, treatment may not be indicated in the first place for some of those women to prevent mother-to-child transmission. And you pointed out the difference between 77 million and 14 million, I think. So you're giving a lot of unnecessary, totally unnecessary tenofovir. There's the risk of flares. People understate those flares, but they are problematic. In a pregnant woman where there are enormous immunologic perturbations, people like Kumar Viswanathan have shown that these flares are very dangerous in pregnancy. You have a woman who's postpartum, breastfeeding, and suddenly has a flare in her hepatitis B. I think it's totally unpredictable and really difficult to manage in rural polyclinic settings, etc. There's the risk of fulminant hepatitis. People argue these flares are rare. They're not so rare. There are large databases from Taiwan where in the initial period of treatment, nucleoside analogs were only prescribed for a year. People have kept databases to show that they're not uncommon, and severe hepatitis is not uncommon. In clinical trials, we're not stopping the nuke unless we have very low HBsAg concentrations, and the FDA is very concerned about fulminant hepatitis in new clinical trials where the nuke has been stopped. You're not treating some of the mothers who should go on to continue treatment by not measuring their DNA status or E antigen status. There's no data at a population level. The much vaunted Uzbekistan studies where they were going to treat 100,000 people with surface antigen, I don't think it's materialized and not been published. So there are lots of real issues. It's okay to model, but to advocate this, I think, would be a different matter.
Yeah, thanks, Jeff. And I think, yeah, I'm definitely not an advocate for a strategy that hasn't been tested and with, with just theoretical, it could have, good impact and cost effectiveness, but I'm acutely aware, and I would, caution exactly the things you've said, the flares, the over-treatment, is it acceptable to women to have treatment in pregnancy? Yes, we know tenofovir is safe, but does a pregnant woman want a drug that they don't need? And, as a physician, do I want to offer that to a patient that they, just because we can't get the costs, we can't get access to cost of diagnostics down, etc. The other thing I say, again, like you were saying, who do we continue lifelong? Who needs it for their own maternal health? And going back to Manal's point of taking this family approach and not forgetting the woman, actually, if we're going to decide who needs to continue the tenofovir for her own health, we're going to have to do a DNA anyway. So you're not you're not avoiding the DNA, the question by treating all in pregnancy. And also, I think if you're treating, say, it depends on the country and the setting, but if, say, 1 woman out of 10, probably less, or Hep B positive, have a high viral load, need treatment in pregnancy, you could maybe focus your efforts and healthcare resources on really getting that 1 woman to take her treatment throughout pregnancy to prevent the risk that we know is high in that woman. Whereas if you're giving tenofovir to all 10 without any risk stratification, you have to sort of treat them all as high risk, and maybe you don't have the resources to really focus on the counselling on the one of those 10 that might be really high risk. So I think there's definitely pros and cons, and it again needs empirical testing about acceptability, feasibility, safety, etc. before it's a widely rolled out strategy. I agree.
Thanks, Shiv. We've got one more question.
Oh, thank you for the talk. Very similar question, essentially. It would be more the practical side of what, essentially it's been answered, what to do after the pregnancy, in terms of you can't really use the viral load at that point anymore, having been on a suppressive drug, to risk stratify your patient whether they do or do not need lifelong therapy. So it would be difficult to sort of make a decision at that point to continue, and then to cease therapy would run the risk of flare, but very similar.
Thanks for that. I don't know if you managed to hear all of that, Shiv, but yeah, definitely lots of pros and cons, but maybe, yeah, you've got another question coming. Just to, if you've got questions for Manal that you didn't manage to ask earlier on, we've got ample time to entertain questions, but over to you.
Sorry, just to push back on one of the pros which wasn't mentioned, though the cons were very well articulated. In East and Southern Africa, there's a high incidence of HIV during the pregnancy and peripartum period. And there's a huge movement to scale up PrEP, HIV pre-exposure prophylaxis to pregnant women right now. And so that's another big pro, is that if you did initiate this pregnant woman on hepatitis B therapy, you're also keeping her HIV free during the period which is at high risk, and also high risk to transmit to the baby. Over.
Great.
But one other con we did not mention is the effect of the tenofovir on the growth of the baby and on the kidney. And there are some studies showing that there is a negative effect. But now they're looking at TAF, and they're looking at whether TAF is having the exact negative effect on the babies, or it's a different story.
Shevanthi, you touched on this. I just wanted to clarify that in your studies of the cost effectiveness of maternal screening to guide vaccination and antiviral prophylaxis for the infant, you don't really model the impact on the mother, if that indeed does inform the clinical care of the mother and the health benefits in that regard. And then by extension, Manal was mentioning a family approach. So just wondering, is that something that we can model to actually look at the full impact of a comprehensive approach, interventions thereafter?
We didn't, because we just did the final cover that pregnancy. We could, who would we carry on because the former mother, probably, unless she clears the virus, right. But health benefits for the mother. But just to say, most of the will be at low risk of having severe disease and requiring antiviral therapy for their own. That's just something to weigh up, and they're not necessarily going to progress to severe liver disease, but
true. But maybe they're one diagnosed and have a for appropriate care.
Yeah.
Any other questions?
To ask about the PMT only therapy for women. It was for the PMTCT for HIV, prevention. You need to give the lamivudine or the emtricitabine. So if you're using tenofovir, hepatitis B going into the successfully also preventing HIV acquisition in our high prevalence of HIV.
Shiv, do you want to take that? Or Manal, do you want to take that?
No, Michael may be able to.
Well, there's an abstract here that I kind of snaked in, and it sort of showed that patients who were on anti-Hep B, as in tenofovir, were actually prevented from getting HIV. So quite exciting. So maybe in short, there is some element of prevention from monotherapy. Yeah, another question there.
Just wanted to kind of weigh in on the discussion about risks of tenofovir in pregnancy. So there's a kind of instinct to be risk averse about giving women treatments in pregnancy. And Jeff, it's interesting to hear your kind of concerns about flares. Just to sort of present the other end of that spectrum, there is a sense that we probably treat lots of people who stop and start tenofovir, and that flares may not be as common as we think, and that in fact the kind of very low risk of a flare you could sort of balance against saying, well, there's a strong benefit. And if we're moving outside the setting of pregnancy, if we're moving towards wider treatment, then there might be an argument for saying we also ought to take that proactive treatment approach into pregnancy, where we're doing several things. We're protecting the risk of vertical transmission. We're giving active treatment to a woman. We're protecting future pregnancies and horizontal transmission in that sort of family setting. So I suppose what I'm asking is, how can we sort of weigh up the risks and benefits of that situation, and also the risk to the fetus? There are these kind of concerns about metabolic bone disease and renal dysfunction, but actually if you offset that against the risk of chronic hepatitis, where we know these children are then at significant risk of long-term liver disease and cancer, then you might be willing to kind of accept the small metabolic risks as an offset at the population level against the wider risk. I don't have answers to these. I'm just kind of presenting a sort of a balanced equation. And I suppose to Shevanthi, whether there's anything we could think about in terms of modelling that sort of risk benefit. And it depends what you accept as a strategic risk, doesn't it? But one thing that I suppose could be thought about is the numeric risk of flares, and whether that's something that we can quantify sufficiently to put it into a model.
Yeah, that's a good point. Yeah, if we can quantify that risk, we can put it in. What's acceptable? I think that's that's a hard thing, because different things will be okay, acceptable for some people and some not others. I mean, I think the caveat to that is, of course, there's a significant risk of liver disease, but mainly in a very small subset. And I think that's what we have to weigh out. If you're treating some people, or some women, young women who would otherwise not need treatment, and then there's a flare or a complication in the baby or in the mother, then that's probably an unacceptable risk. But again, it's balancing up the public health approach, as you say, versus the individual perspective approach, and maybe thinking back to why we're thinking about the universal strategy. And probably, the main reason is because viral load testing is way too expensive. I think that's one of the big elephants in the room. It's, it's too expensive and isn't readily available. So maybe is it worth putting women on unnecessary treatment just because we can't get a viral load test? So yeah, I think again, there's no answers, but I think there's lots of sort of levels of, complexity.
Can I ask you a question, Shevanthi? How much would e-antigen add to the cost? And would it save many mothers also from getting tenofovir when they don't need it?
So the e-antigen at the moment, but unless there's some new studies out, the rapid diagnostic tests for e-antigen haven't been very accurate. So it's still depending probably on a laboratory-based assay, which again, the costs vary between different countries. But what we did in that, one of the figures is compare the cost of the viral load and the e-antigen. So to really look at where on that graph your e-antigen and viral load costs sit, and then you can see which one's a more cost-effective strategy in your country or your setting. So it will be different for every country depending on the costs.
So we need a point-of-care viral load. We go back again, we'll circle back to this point again and again. We need a point-of-care viral load.
The low-cost one,
yeah,
yes.
A low-cost point-of-care viral load.
We've got more questions, comments? Noted. Yeah.
I think we need a point of care of fibrosis. Because some papers show that the natural history in African is very different from Western countries. So to stop tenofovir shortly, so you will miss a lot of patients for prevention from cirrhosis, from cancer. I think it's a point to evaluate.
Thank you. I fully agree, but there's pros and cons. We'll take more questions. John, and then followed by Mark behind John. Oh, I thought you had your hand.
Yeah, thank you, Madam Chair. Shevanthi, just forgive me for my naive question if you didn't cover this area. I think this is a general discussion going on about the prophylaxis use of tenofovir for PMTCT. How about the WHO guideline that recommends the cutoff viral load for 200, starting treating these mothers, basically for prophylaxis? So is this discussion focused on the universal coverage without taking into consideration the cutoff that is being recommended? Because, and what are the benefits if we are doing it universally without testing? Because if we are following the guideline, then it's my recognition that the discussions whether the tenofovir has a consequences for the side effects, the benefits usually will, outweigh the risks. So are we taking into consideration also the viral load? Because this is how also we can advise policymakers, to invest more also in the diagnosis, testing viral load, or even if it is e-antigen also for. What's your take in this?
Thank you. That's very good point. And I think, probably Philippa and others to sort of comment on the threshold, but that was based on, systematic review. And in our analysis, all we did was, take high viral load, low viral load as per WHO guidance, or no viral load at all. There may be some benefits to reducing the viral load if there's no hepatitis B birth dose. But what we were really looking at is overcoming that barrier of not having access to a viral load test or having access to a viral load test that's too expensive in the country. So yes, I think there probably is a different cutoffs, but I think that was explored in the WHO systematic review, and this cutoff was thought to be the optimal to balance out the risks and benefits, as you mentioned.
Thanks. Not to put you on the spot, Wendy Spearman, I'm not looking at you for a good reason. Knowing what you know, I've worked with Wendy for almost 2 decades now. What are your thoughts on test and treat, given the fact that you have had sleepless nights trying to convince the policymakers to implement birth dose vaccines? You know, if you saw a patient with hepatitis B, I mean, I always tell my patients, everyone who's got chronic hepatitis B is for therapy, unless otherwise you want to postpone it for whatever reason. What are your thoughts, Professor Spearman, on test and treat?
I think everybody's putting me on the spot. So, I mean, I think, as we've heard, there are pros and cons. If we're looking at test and treating in the setting of pregnant women who are not going to have access to appropriate point of care DNA testing, and we are still struggling to get hepatitis B birth dose vaccine, then I think there is a role to potentially surface antigen positive, put them onto treatment. But we know that patients don't take their treatments. And my concerns are just like Jeff's concerns, that you do have flares. And I think there's this sort of feeling that if we have test and treat, we somehow take away the need to monitor these patients and follow them up. And so I think it's very important that if we consider that route, it still means that these patients, these pregnant women, need to be in careful follow-up, particularly in that early 6 months post-treatment. And we know from experience, mothers that are on hepatitis B treatment with tenofovir become pregnant are still concerned about taking tenofovir and the risks to their babies. That's the reality. And so we've all seen that. People who are pregnant stopping their tenofovir. So I think it's going to require a lot of counselling, that you need to really continue that treatment, and you need to follow these patients up carefully. So I'm not a proponent of it. I just don't know why we are still being concerned about having an affordable point of care viral load. We can do it for HIV. We monitor HIV every 6 months with a viral load, but somehow for hepatitis B, there's this resistance. It's expensive. I think we have to get over that. We ourselves are actually putting that across. We always put in those barriers. We have to say this is unacceptable, that we can actually get affordable point of care diagnosis. And we go back to COVID. I mean, could scale up in very poor countries rapid PCR platforms. And we know, I mean, I can't remember the number, but we've got Kefiad systems throughout sub-Saharan Africa. Everybody knows how. Community healthcare workers, primary clinics, everybody knows how to do a PCR. Gene expert for TB, for HIV. I think that we need to stop actually saying that is a barrier. We need to insist that we actually bring those, that as a region, we actually motivate to bring those costs down, and we implement that.
Thank you. Thanks. Mark?
Elizabeth, thanks. I wanted to just augment what Wendy said. She took the words out of my head as I sort of put my hand up. But we must be cautious of test and treat becoming a default for, here's your tablet, we're never going to see you again. Let's draw a parallel, and let's go to probably one of the biggest test and treat programs on the planet, and that's for HIV. Because that's really what we do. We test and we treat, particularly in the maternal situation. But that doesn't mean we never see you again.
Yeah.
You get an HIV viral load test in most programs every 6 months to assess your compliance, and in some programs you'll get a CD4 count as well, but that mostly has been dropped. So there's long-term longitudinal follow-up. I think there's this thing that test and treat becomes this cheap option of surface antigen positive, little finger prick test, and then off you go, we never see you again. No. If we're going to do test and treat, then we commit to 6 monthly viral load testing, or annually, or whatever we decide. That still then winds back to Shevanthi, the issue you've raised, which is the elephant in the room, and this is the viral load test. And I want to just ask the question, because maybe I'm becoming like a stuck record today. Is we talking, and Wendy, you just spoke about an affordable point of care viral load test. Do we do that for HIV? Do we have point of care viral load testing in HIV programs? I'm just asking the question. Why? I mean, certainly I can speak for our own backyard. The viral load testing has been rapidly upscaled within our laboratory systems and our national health laboratory system for HIV. I speak now for South Africa, can't speak for other countries, we don't do point-of-care viral load testing for HIV. Why are we talking about doing this for hepatitis B? Is it because we want to try and at least do something? Or are we again trying to almost dumb ourselves down? And I use that word very loosely, I don't mean it in an unfortunate way. Is it because we're trying to be apologists for what we want to do? We must stand up and say, this is what we need to do, and this is what is needed in the interests of maternal care. Finish in class, they would say in South Africa. That's it. That is what's needed to do, and it comes back to the point I've made the whole day. What is it about viral hepatitis? What is it? We need to get to that answer as to why this doesn't happen. All the things to prevent it, it doesn't like it should. Why?
Yeah.
No.
Political advocacy, no. Stars. No, you don't have stars come out and advocated for it like HIV. You don't Week and Time that had the front page for many, many years, and advocacy from community of things, Mark. So we need to be talking about this for many years. Find me, we can work with.
Sorry. It's a dialogue between Mark and Manal. Sorry,
Yeah,
Philippa.
Right.
I think there is one fundamental difference, is that with hepatitis B and hepatitis C, we require a viral load to establish eligibility for treatment. With HIV, treatment is based on an antibody test alone. The viral load is used for monitoring, except in the case of the diagnosis of early infant diagnosis, where you're using a viral. So this is fundamentally different. I completely agree that for the decades with HIV, the price of the viral load never came down. And that was a big impediment. And I think actually just reflecting on the HIV experience, because that was very much my world, and that's where I think there was a misstep in the public health approach, in the quest to ensure and expand access to ARVs. A decision was made to deprioritize viral load monitoring. And as a result, we saw the dividends, the negative dividends, where there were people who were failing treatment who weren't recognized, and then they had drug-resistant disease. But put that aside, I think the point I was responding to, that things are different. And actually, in a much shorter period of time, we've seen finally a reduction in the costs of viral load with hepatitis C. We now have the recommendation for a point of care Hep C viral load as an alternate to lab. There's now bundle procurement. Chai has achieved within, for example, in Rwanda, $60 for both treatment and the 2 viral loads for diagnosis and cure. And we're seeing lower and lower costs, well less than $10 in many countries. Hepatitis B is next in line in terms of a recommendation for a point of care viral load as an alternate. And I have the expectation that we will start to see a decline in the viral load costs for hepatitis B too, and they'll be more accessible. But the original point I was going to make, and then I had to respond to Mark's point, was I don't think we should call it test and treat. This is test and prophylax. Yeah. Test and treat is something quite different and very much in the context of HIV. That's relevant. For hepatitis C, it's relevant. But it's test and prophylax. And I think a final point on this existential issue that we're embarking on, I think Wendy's point of, really that the push should be in access to the viral load rather than taking the shortcut. And that is the fundamental debate, whether in the interim we offer something that can be couched, and this is the sort of advantage of some of the WHO recommendations. You can have strong and conditional is where you apply the conditionality, where you do not have, and where it is fully appreciated, these are the considerations and downsides, this can be an option. You're not promoting this in all settings, in all contexts. It is very context specific. And so it's whether that option is extended with support based on modeling, because that's probably about as good as it's going to get, and a clear exposition of the pros and the cons and the considerations, whether until such time as there's more ready access, you provide that option. And we are very much talking about sub-Saharan Africa. Because, you know, e-antigen and DNA is much more available in other settings, and it's where you've got a low e-antigen prevalence setting anyway. So that's my little speech.
Thank you. Thanks, Philippa. Michael, you had a...
Hi, Michael again. And I think I also take Mark's point in that when you look at the sample journey, whether it's HIV or hepatitis, it's the same sample journey. And but the challenge that I see here, and I'll give South Africa as an example, I think we like to complicate things. We like to complicate the whole hepatitis B and C story to make it almost difficult. And I'll give this example. I wish there was someone from NHLS here.
Yeah.
Okay, so I watch what I say. But to the best of my understanding, and you can correct me, maybe wrong here, that to get a PCR test, you need to have done serology first. And doing a rapid test is not recognized. Is that the case? No, not HIV. I'm talking about hepatitis. In hepatitis. Okay. So to the best of my knowledge, that's what's happening. So people running programs, let's say PWID, or running programs in Port Elizabeth, Eastern Cape, they would do a screen rapid, but no, you need to still do a full-on serology. Now you enter into a more, you start with serology first, and then you wait for that result to come through from a centralized. And then you go into having a PCR. And not to say that PCR is going to be done where there's a machine there. There's an install base that's good enough in that particular area. It still then goes to either Cape Town or Johannesburg or Gauteng. So why does then hepatitis need to follow such a convoluted channel, but HIV doesn't, right? When you look at it, really, it's just the same sample journey that needs to be followed. I think there are a bunch of suppliers here. Where's Abbott? Put your hands up. Rose should be here as well. All these suppliers are here, and they come up and they all scream that we have access pricing for hepatitis C and hepatitis B. But this access pricing, is it filtering down? I don't know. But they are doing their part to a certain extent, but I think we need to have a look at this, not just from treatment, not just from patient factors, but who in the whole value chain, who in the whole patient journey is involved in us being successful to get to our elimination targets. And everybody sits in the same room, thank you, NHLS. Everybody sits in the same room, and people put in and chip in and put in their part. If we don't do that, and we still have the siloed approach, where Wendy is writing to AU NAPID, she's, fighting the good fight, but in a silo, it's going to be, again, 4, 5, 6 years until we realize something. But if we can get this multidisciplinary team, and we all stand up and commit today and say, I am NHLS and I will make sure that this happens, I am treating, and I'll make sure this happens. And we all commit and we write and we put our names and our home addresses with our phone numbers so that we can find you. Then we start to move the needle. Thank you.
Thanks,
we actually tested the whole population, rapid test and PCR. We did not test anything in the middle. It was just rapid test and PCR. And initially, there was insistence that we do ELISA tests. And we rejected that because the target was the whole adult population in 6 or 7 months. And that was the presidential initiative. He said no. We said 3 years. He said no. You have 1 year, 3 months of preparation, and then we started, and in 7 months we screened the whole population. It was only rapid test, and rapid test, immediately you are transferred for PCR, and that's it. So why ELISA? They said we purchased 12 million ELISAs from one company, and you have to use them. We said it's not possible, because you need trained people on venipuncture, and there are lots of accidents that are bound to happen if you go for national screening using an ELISA test. People might get a vasovagal attack and die. If they see blood, it happens. It happens. It's one. We're talking about millions and tens of millions, and it happens, and it's bound to happen. And that was my argument with the people who insisted. They said, we already have an agreement and signed. I said, it's not going to work. You can use this in the labs. Keep this in the labs, give it to the labs, and tell them if anybody comes for a checkup, use those free tests and check them, and go on the system and register them. But we cannot use this as a point of care and go all around the country in mosques, in schools, in clubs, and everywhere. It was all over Egypt. You can't use this. And it's not. I don't see any rationale behind an intermediate test between rapid test and PCR. So thank you for this.
Yeah, I like that. Keyword is simplify. I mean, we've got a couple of fellows here. If I were to ask them to interpret serology for hepatitis B, you'll get interesting answers. Surface antigen and consider, and yes, Mark, thank you for clarifying that. It's not just test and treat, it's test. Surface antigen positive equals to active disease, and active disease equals to treatment. And the question is when? And if a patient is willing, that patient should be given therapy. So I like simplifying things, and hepatitis B has been a problem for quite some time, and I'm with Michael in this one. Let's stand together, let's test people, and let's treat, and let's not hide behind serology. I was gonna comment in that NHLS form, for hepatitis B, you've got 2 blocks, hepatitis immunity, right? Hepatitis clinical, hepatitis B clinical, and you ask your interns, what are you asking for? They have no idea. They have no idea. Now, there's 3 of us here, Wendy, myself, and Mark, the only hepatologist in Cape Town. So if we're gonna do hepatitis B surface antigen, then look at the E antigen, and we will lose a lot of patients. And if we look at it this way, if you prevent one transmission, one mother-to-child transmission, you're literally preventing 25 other infections. I've got a 3-year-old, it's vaccinated, yes, in child care or in play school. If there is one child in that class who has hepatitis B, all of those children will be infected. Why? Because they scratch each other, they bite each other. So yes, vasovagal, yes, flares, yes. I think if we want to achieve the WHO, we should adopt a simple approach, which is, I'm with you, Zambia. Zambia, right? Good.
All right, thank you. All right.
Thank you.
I think we have one more question.
I think we're out of time, so it has to be quick. But, but you haven't spoken in the session, so let's please go ahead. Please comment.
Sorry.
Please go ahead.
I got greedy there.
Okay. The last comment, please go ahead.
My name is Dr. Mulaudzi. I'm from South Africa. I'm a GP in private practice. Most of the arguments here, I realize that they are more to do with public health. One of the things which Professor Mark Sonderov said is that, asking you, John, is that why is hepatitis, viral hepatitis, not sexy? Is it?
I've already answered that question.
Yeah, and I have to say South Africa has got two economies. We've got the first world and the third world economy. And one of the things in the first world economy, which is private, is that hepatitis B treatment is only for specialists. When we started with HIV at the beginning, it was also not sexy until the infectious disease specialists scaled it down and did just shifting to both the general practitioner and also the nurses. And then if we're to address also that issue of it being acceptable, I mean, the average GP in South Africa has no idea what viral hepatitis is. And when we're doing maternal health, even when we do blood tests for antenatal bloods, it is included as part of the screening test. But you have no idea what to do when the viral, the test becomes positive. Yeah. And worst of all, the medical insurance section, they don't even pay for the viral loads. So you end up actually not knowing what to do. Mm-hmm. Yeah. Secondly, the issue of the viral load testing. When we started with HIV treatment, it was never test and treat. It was actually based on the viral load. It was not, it started on the CD4 count, then on the viral load. So the viral load at that time were quite expensive. But the government, even in public, they never faltered. They went on to actually pay because it was a basic test to be done when you want to give treatment for HIV positive patients. So the cost for the viral loads only went down when there was a high uptake of the viral load test. Yep. I think when it started in the 1990s, it was around about 6,000 to 8,000 rands per person. But right now it's actually around 500 rand. I can't interpret in dollars. $20 or $30 per test for a viral load for HIV. With Mark, it can be done. We don't have to wait. It is available in the private labs. And if the uptake is higher, cost will go down. And I think there will be more access, which will benefit from this.
Thank you.
Those are all decentrify, simplify, and then create the demand that can lower the cost to make it more affordable. And we'll be touching on a number of those points tomorrow. So that's a good segue for tomorrow. So we're going to close this session. Yeah, it's been very vibrant. I thought we had 45 minutes of great discussion. So thank you all for a job well done and very energized.